أعزائي الطلبة، آه، السلام عليكم ورحمة الله وبركاته. هذه المحاضرة الثالثة about acute inflammation, and this lecture will be dedicated mainly to discuss all the aspects of the chemical mediators. أعزائي الطلبة، السلام عليكم ورحمة الله وبركاته. هذه المحاضرة الثالثة about acute inflammation, and this lecture will be dedicated mainly to discuss all the aspects of the chemical mediators. So, what are chemical mediators of inflammation? The mediators of inflammation are the substances that initiate and regulate inflammatory reactions. The hurried students may find the list of mediators daunting, as do professors. Actually, it's a long list of mediators and it keeps changing all the time. However, we'll be focusing on the main mediators, on the main chemical mediators in this lecture. I will emphasize the important ones in the following slides. This knowledge about chemical mediators has been used to design a large armamentarium of anti-inflammatory agents that are used every day by many people and which include familiar drugs such as aspirin and acetaminophen. So the knowledge about these mediators is very important to understand the mechanisms of the different anti-inflammatory agents, which are probably the most commonly used drugs, especially over shelf. The mediators may be produced locally by cells at the site of inflammation or may be derived from circulating inactive precursors that are activated at the site of inflammation. So, what are the sources of these chemical mediators? There are two main sources, as you see here in this slide. First source is from the circulating plasma proteins, and these include the following categories of the chemical mediators: the coagulation fibrinolytic factors, the complement system factors, and the kinins. The other major source of these chemical mediators are cell-derived, and these cell-derived ones can be either formed elements normally sequestered in the granules within the cells, and the best example on that is the vasoactive amines, or newly synthesized mediators in response to stimulation. And this includes probably the largest list of these chemical mediators, including the prostaglandins, the leukotrienes, the O2 species, the nitric oxide, cytokines, and platelet activating factor. Systemic mediators or chemical mediators of inflammation. As you see in the blue area there, you can see the cell-derived chemical mediators, and as we just mentioned, there are two subcategories there. One of them is the preformed mediators in secretory granules, which means that they are already synthesized and already present within the granules of the leukocytes. And the main groups or the main categories of these include the histamine and the serotonin. The histamine is secreted by the mast cells, the basophils, and the platelets, whereas the serotonin is released by platelets or secreted by the platelets. The other main category, which are the newly synthesized chemical mediators, and this includes the prostaglandins, leukotrienes, platelet activating factors. Of course, these are produced by leukocytes. Prostaglandins can be produced by mast cells as well as the leukotrienes, The platelet activating factor, in addition to leukocytes, can be secreted by the endothelial cells. The reactive oxygen species, as we discussed earlier, also can be secreted by all leukocytes. And nitric oxide, the main source of nitric oxide, is the macrophage as well as the endothelial cells. The cytokines group is secreted by macrophages, lymphocytes, endothelial cells, and mast cells. Peptides is also secreted by leukocytes or nerve fibers. So these are all cell derived, which means they are produced by the cells, which are mainly the leukocytes as well as the endothelial cells and platelets. The plasma protein derived chemical mediators, which means they are derived from the proteins which are already present within the plasma. And the major source for these plasma proteins, as probably you know, is the liver, is the major source. So these plasma proteins can be either complement, part of the complement system, and when there is activation for the complement, this will lead to release some of these factors, including C3A or 5A or C3B or the membrane attack complex, which is the C5b29. The other one, which results from factor 12 activation, which we call it Hagman activation, this will lead to the secretion of the kinin mediators or the coagulation fibrinolysis system mediators. And we will be discussing these in details in the later slides. There are some general characteristics for all the chemical mediators of inflammation. These mediators can bind to specific cellular receptors, as we have already seen, where these mediators can bind to a ligand or a receptor on the cell itself, or to have an enzymatic activity, a generalized enzymatic activity to induce or augment further inflammation, for example, or to suppress the function of some of the secretions of other cellular secretions. Or this might stimulate target cells to release secondary mediators. These secondary mediators can have either similar or opposing functions of the primary mediator. So these mediators can induce the cells or stimulate them to produce a similar mediators which will augment or exaggerate the inflammatory process, or sometimes can stimulate these cells to produce another factors which has opposing functions. They might have limited targets or widespread activities with widespread targets. Generally, these chemical mediators are short, they have short-lived function, which means they have short half-life, like the arachidonic acid metabolites, or it can be inactivated by enzymes like kinases or bradykinin, or it can be eliminated by antioxidants like on the O2 species, or inhibited by other proteins like the complement inhibitory proteins. However, if these chemical mediators goes unchecked or uncontrolled for a long time, which means not properly regulated, they might cause harm to the site of the inflammation, or can produce systematic effect to harm the whole body. So it's very important actually to monitor these kind of exacerbation of inflammation, which sometimes might reflect some cytokine or chemical mediator exacerbation of this inflammation. Probably you have heard during the COVID-19 outbreak or pandemic about what's so-called the cytokine storm. which was thought to be the main cause or the leading cause of death in those patients who are infected by the virus, coronavirus. And this cytokine storm is again, it's a kind of an exaggeration or exacerbated uh, inflammatory process which might lead to the sudden death of those patients. The major cell types that produce mediators of acute inflammation are tissue macrophages, dendritic cells, and mast cells. But platelets, neutrophils, endothelial cells, and most epithelia also can be induced to elaborate some of these mediators. So main sources of these mediators in acute inflammation are the macrophages and other mast cells or dendritic cells, but still platelets, endothelial, and neutrophils also can be induced to do such elaboration or release of these chemical mediators. The cell derived mediators are most important for reactions against offending agents in tissues, as we will see later. The plasma derived mediators, which include like the complement proteins produced mainly by the liver, are present in the circulation as inactive precursors that must be activated usually by a series of proteolytic cleavage to acquire their biologic properties and are effective against circulating microbes, but also can be recruited into the tissues at the site of inflammation. So these proteins, plasma proteins, need to be activated before they can start exert its effect or action during the inflammatory process. This table is a nice one which summarizes the principal mediators of inflammation, where it includes the most important chemical mediators with their source and their action. And as you see, this table includes the chemical mediators, whether they are cell derived or plasma proteins, okay, and even those cell derived, whether they are preformed in the cells or newly synthesized. As you see here, for example, histamine, the main source is mast cells and basophils and platelets, and its main action is vasodilatation and increased vascular permeability and endothelial activation. Prostaglandin or glandins, which is secreted by mast cells and leukocytes, their main action is vasodilatation and induces pain and fever, as you will see later. And it continues like this. So I would advise you to read this table very carefully, and it summarizes probably the most important aspects of the chemical mediations. You see here the leukotrienes, the cytokines, the chemokines, the platelet activating factors, as well as the other plasma proteins, including the complement and the kinins. You see here the complement, which are produced mainly in the liver, and the main source is the plasma because these are circulating plasma proteins. And for example, their main action is leukocyte chemotaxis and activation with direct target killing by the membrane attack complex and also cause vasodilatation. The kinins also, which is produced in the liver and is circulating in the plasma, it leads to increased vascular permeability and a smooth muscle contraction, as well as vasodilatation and pain. Now we will be discussing some of these individual chemical mediators, and we will start by the histamine and serotonin. And as I just mentioned, probably in the first lecture, that histamine and serotonin were the first described as chemical mediators by scientists in the 20th century. And these were so named because they have important actions on the blood vessels, which means why they are vasoactive amines, which means they exert their action on the blood vessels, and that's why they are vasoactive. And these are stored in granules in mast cells, in histamine, where these granules in mast cells lead to secretion of histamine, or in platelets, where these secrete the serotonin. So, serotonin in platelets and histamine in mast cells. And these vasoactive amines cause arteriolar dilatation and increases the permeability of venules. So vasodilatation and increase permeability or vascular permeability. And they induce endothelial cell contraction in venules and binds to H1 receptors on the microvascular endothelial cells for the histamine vasoactive amine. The histamine is inactivated by histaminase, and this actually has formed the basis of the antihistamine drugs. So it provided us the understanding of the exact mechanisms of this histamine, and this has been utilized in the pharmaceutical industry where these antihistamine drugs اللي هم الأدوية الانتيستامينز اللي بنستخدمهم أدوية الحساسية بشكل عام الالرجيز and used to treat اللي هم الالرجيز اللي هم عبارة عن H1 receptor antagonists which bind to and block the H1 receptors. So these were specifically designed according to our standing to the of the mechanism of the histamine and their effect on the blood vessels. So, what are the stimulants to release histamine and serotonin? So we can see on the left side that the release of histamine is induced by physical injury like trauma, cold, heat, or binding of IgE to Fc receptors, or due to anaphylatoxin binding like the C3A or C5A, which are part of the complement system, or histamine releasing protein derived from polymorph nuclear cells اللي هم neutrophils BMNs, or as a result of neuropeptides or substance B induction, or by cytokines including the interleukin 1 and interleukin 8. Release of serotonin is induced by platelet aggregation or by the release of platelet activating factor. One of the main chemical mediators category is the arachidonic acid metabolites. And again, this group of mediators has been the target of a lot of pharmaceutical industry. The metabolites and the antagonizing the effect of these metabolites has been the target for a lot of medications, drug or pharmaceutical research for probably the past 56 years. So arachidonic acid, as probably you know, is a 20 carbon polyunsaturated fatty acid that is derived from dietary sources or by conversion from the essential fatty acid اللي هو linoleic acid. Most cellular arachidonic acid is esterified and incorporated into membrane phospholipids. So most of the sources of the arachidonic acid metabolites are basically from the membrane phospholipids. The mechanical, chemical, and physical stimuli or other mediators like C5A will trigger the release of arachidonic acid from membranes by activating cellular phospholipases, mainly phospholipase A2, as we will see in the next slide. Once freed from the membrane, the arachidonic acid is rapidly converted to bioactive mediators. After it is released there, these mediators are also called as the eicosanoids because they are derived from the 20 carbon fatty acids. You know that eicosa in Greek means 20. This is a simple actually diagram where it shows that the release of arachidonic acid from the membrane phospholipids is induced by the action of the phospholipase A2. So this will release the arachidonic acids, which can further undergo into two pathways. One of these is called the cyclooxygenase pathway, and the other is the lipooxygenase pathway. The cyclooxygenase pathway will lead to the formation of prostaglandins, a family of chemical mediators. We call it prostaglandins. And these include prostaglandin E2 or F2 or D2 or I2 or thromboxane A2. So كلهم هذولا بنسميهم these are the family of prostaglandins. On the other side, the lipooxygenase pathway will lead to the formation of the leukotrienes and lipoxygens, and we will discuss this again in further details. And this includes the leukotriene B4 and C4D4E4 and the HETI group, as we will see later. This is a more detailed diagram which shows all the arachidonic acid metabolites with their effect. So you can see here that the cell membrane phospholipids and upon the action of the phospholipases will lead to the release of the arachidonic acid. This arachidonic acid, it can be further undergo two main pathways, which include the cyclooxygenase. Under the effect of the cyclooxygenase, this will lead to the formation of the prostaglandins, as you see on the left side, prostaglandin G2, H2, and then the prostacyclin, which is the prostaglandin I2, as well as the thromboxane A2 or prostaglandin D2 or E2. This is on the left side. On the right side, you see in the lipooxygenase pathway, this will lead to the formation of the HETI, which is the hydroxyeicosanotetraionic acid, as you see at the bottom of this slide, or to the conversion into the different leukotrienes, including leukotriene B4, which is more or less have the same effect of the 5-HETI, or the other leukotrienes, including the C4, D4, and E4. طبعا these leukotrienes, the C4, D4, E4, will lead to bronchospasm and increased vascular permeability, whereas the main function of the leukotrienes B4 and 5-HETI is the chemotaxis. And the other lipoxygenase pathway, which is the 12 lipoxygenase, this will lead to the formation of the lipoxygen A4 and B4 with their main action of inhibition of inflammation. So they have rather an inhibitory effect on the inflammatory process. Again, now back to the cyclooxygenase pathway here, or let us start actually from the top, where you see that steroid inhibits mainly phospholipases. So steroids is a generic inhibitor of inflammation, which inhibits all further generation of arachidonic acid metabolites, and that's why usually using steroids sometimes have some kind of initial magic effect, because it subsides and suppresses the whole inflammatory processes in the body. Now, for the cyclooxygenase pathway, you can see there are the COX-1 and COX-2 inhibitors, as well as aspirin indomethacins, which inhibit mainly the cyclooxygenase. طبعا, of course, this will lead to inhibition and blockage, the further degradation or the formation of the prostaglandins. Please note here on the left side the effect of the different prostaglandins. As you see that prostaglandin I2, which is prostacyclin, as well as the prostaglandin D2 and E2, causes vasodilatation and increase in the vascular permeability, as well as inhibiting of the platelet aggregation. Whereas thromboxane A2, although it is one of the prostaglandins, but it causes vasoconstriction and promotes platelet aggregation, which means it has the opposite effect of the other prostaglandins, which means it more or less it has some similar effect of the leukotrienes, as we will see later on. So it's very important. Now we will see that the difference between the COX-1 and the COX-2 inhibitors. COX-2 is believed to be a more selective inhibitor of inflammation, because the COX-1 inhibition will predispose or might lead to the effect on the stomach or gastric ulceration, as we'll discuss later. Here on the right side, on the leukotrienes side, you can see here, these leukotrienes cause bronchospasm, so their effect on the smooth muscle of the airways, and therefore this form the basis for the leukotriene receptor antagonist, which will inhibit the effect, and it means it's used mainly in bronchial asthma. So again here, to just further discuss the products of the cyclooxygenase pathway of arachidonic acid metabolism. And again, you see here thromboxane A2, as we just mentioned, زي ما حكينا, بتعمل vasoconstriction and stimulate platelet aggregation and thrombosis. And this is important لأنه راح نشوف بعد شوي في ال COX-2 inhibitors why this predisposed to thrombosis. I will discuss later. So just keep this in mind. Prostaglandin I2, which is the prostacyclin, causes vasodilatation and inhibits platelet aggregation, so acts thromboxane. Prostaglandin D2, E2, and F2 lead to vasodilatation, like prostacyclin, and edema formation, as well as pain. So the main mediator of pain is prostaglandin E2. So prostaglandins involved in pathogenesis of pain and fever, which are two common systemic manifestations of inflammation. Also, prostaglandin E2 makes the skin hypersensitive to painful stimuli and causes fever during infection. Okay. So again here, to just further discuss the products of the cyclooxygenase pathway of arachidonic acid metabolism. And again, you see here thromboxane A2, as we just mentioned, زي ما حكينا, بتعمل vasoconstriction and stimulate platelet aggregation and thrombosis. And this is important لأنه راح نشوف بعد شوي في ال COX-2 inhibitors why this predisposed to thrombosis. I will discuss later. So just keep this in mind. Prostaglandin I2, which is the prostacyclin, causes vasodilatation and inhibits platelet aggregation, so acts thromboxane. Prostaglandin D2, E2, and F2 lead to vasodilatation, like prostacyclin, and edema formation, as well as pain. So the main mediator of pain is prostaglandin E2. So prostaglandins involved in pathogenesis of pain and fever, which are two common systemic manifestations of inflammation. Also, prostaglandin E2 makes the skin hypersensitive to painful stimuli and causes fever during infection. Okay. On the other side, the products of lipoxygenase pathway includes the 5-HTs زي ما حكينا واللeukotriene B4, which is main action is chemotactic. The other leukotrienes induce vasoconstriction and bronchospasm as well as increased vascular permeability. عشان هيك حكينا إنه الانتagonists for these leukotrienes are used to treat bronchial asthma. The lipoxins, اللي هو lipoxin A4 and B4, causes vasodilatation and inhibits neutrophil chemotaxis and adhesion and stimulate monocyte adhesion. Now إذا بنعمل شوية summary للprincipal actions of the arachidonic acid metabolites in inflammation, we see here that dilatation is mainly caused by prostaglandins اللي حكيناهم, whereas vasoconstriction is induced by thromboxane A2, which is one of the prostaglandins, as well as the other leukotrienes اللي هم C, D, E. Increased vascular permeability is mainly induced by leukotrienes. The chemotaxis and leukocyte adhesions is induced by the B4 as well as HT, and smooth muscle contraction is induced by prostaglandins اللي هم C4, D4, and E4. This is just a quick summary for the previous discussed aspects of these metabolites. Now, so what are the pharmacological aspects of these chemical mediators of inflammation? So we do have the hormonal inhibitors of prostaglandins and leukotrienes. زي ما حكينا إنه the good understanding and the better understanding of all these arachidonic acid metabolites has facilitated actually the discovery and the formulation of specific antagonists or inhibitors of these mediators. So the first category is the cyclooxygenase inhibitors, which includes the aspirin and other non-steroidal anti-inflammatory drugs such as ibuprofen. And aspirin, ibuprofen, NSAIDs, non-steroidals, هذول من الأشياء اللي most commonly used medications, especially over shelf without prescription. ولازم we have to understand exactly their mechanism and their side effects as well. طبعا the main action إنهم they inhibit both the COX-1 and COX-2 and thus block all prostaglandin synthesis. Okay, these cyclooxygenase اللي هم broad cyclooxygenase inhibitors, and they are efficient in treating pain and fever. However, اللي هم selective COX-2 inhibitors are a newer class of these drugs that are 200 to 300-fold more potent in blocking COX-2 than COX-1. And this is important لأنه COX-1 is responsible for the production of prostaglandin. The prostaglandin is involved both in inflammation بس كمان involved بالphysiological function as a protecting gastric epithelial cells from the acid-induced injury اللي هو. So it has a gastric protective. The prostaglandin is very important in protection the mucosa of the stomach. لما بنعمل suppression of the prostaglandin, this make the stomach more liable for ulceration or erosion, especially when using these medications. So, COX-2 generates prostaglandins that are involved only in inflammation. So that's why we are targeting COX-2 اللي هن بسموهم selective COX-2 inhibitors, because we only want to stop the prostaglandins اللي involved in inflammation, not involved in gastric protection for example. However, طبعا هذول في الجروبس بتعرفوهم بجوز اللي هم السيلبريكس والفايوكس and other similar groups اللي هم they are selective COX-2 inhibitors. Although they are good and potent and selective, but at the same time they increase the risk of thrombosis. And why they increase the risk of thrombosis؟ زي ما بتذكروا حكينا انهم they don't exert their effect على الثرومبوكسين A2. والثرومبوكسين A2 it promotes platelet aggregation. So this means they become more liable for thrombosis and cardiovascular diseases. Now, so what are the pharmacological aspects of these chemical mediators of inflammation? So we do have the hormonal inhibitors of prostaglandins and leukotrienes. زي ما حكينا إنه the good understanding and the better understanding of all these arachidonic acid metabolites has facilitated actually the discovery and the formulation of specific antagonists or inhibitors of these mediators. So the first category is the cyclooxygenase inhibitors, which includes the aspirin and other non-steroidal anti-inflammatory drugs such as ibuprofen. And you know, aspirin, ibuprofen, الانسيدز non-steroidals هذول من الأشياء اللي most commonly used medications especially over shelf يعني without prescription. ولازم we have to understand exactly their mechanism and their side effects as well. طبعا the main action انهم they inhibit both the COX-1 and COX-2 and thus block all prostaglandin synthesis. Okay, these cyclooxygenase اللي هم broad cyclooxygenase inhibitors, and they are efficient in treating pain and fever. However, اللي هم selective COX-2 inhibitors are a newer class of these drugs that are 200 to 300 fold more potent in blocking COX-2 than COX-1. And this is important لأنه ال COX-1 is responsible for the production of prostaglandin. The prostaglandin is involved both in inflammation بس كمان involved بالphysiological function as a protecting gastric epithelial cells from the acid-induced injury اللي هو. So it has a gastric protective. The prostaglandin is very important in protection the mucosa of the stomach. لما بنعمل suppression of the prostaglandin, this make the stomach more liable for ulceration or erosion, especially when using these medications. So, COX-2 generates prostaglandins that are involved in only in inflammation. So that's why we are targeting COX-2 اللي هن بسموهم selective COX-2 inhibitors, because we only want to stop the prostaglandins اللي involved in inflammation, not involved in gastric protection for example. However, طبعا هذول في الجروبس بتعرفوهم بجوز اللي هم السيلبريكس والفايوكس and other similar groups اللي هم they are selective COX-2 inhibitors. Although they are good and potent and selective, but at the same time they increase the risk of thrombosis. And why they increase the risk of thrombosis؟ زي ما بتذكروا حكينا انهم they don't exert their effect على الثرومبوكسين A2. والثرومبوكسين A2 it promotes platelet aggregation. So this means they become more liable for thrombosis and cardiovascular diseases. Again here بس عشان نذكركم مرة ثانية, steroids inhibit the phospholipase. COX-1, COX-2 اللي هم broad COX-1, COX-2 inhibitors including aspirin, indomethacins or the non-steroidal anti-inflammatory drugs inhibit the cyclooxygenase as you see here. طبعا لما يكون في عندنا COX-2 inhibitors which is selective, it inhibits the prostaglandins involved in inflammation but does not suppress the thromboxane, and that's why this might enhance thrombosis and lead to cardiovascular diseases. Lipoxygenase here, as you see here, you know, the leukotrienes and the others اللي هم lipoxins. Lipoxins, they have anti-inflammatory where they inhibit neutrophil adhesion and chemotaxis. The second category is the lipoxygenase inhibitors اللي هم ال 5 lipoxygenase is not affected by the NSAIDs, non-steroidal anti-inflammatory drugs. Many new inhibitors of this enzyme pathway has been developed. The pharmacological agents that inhibit the leukotriene production like the gelatin are useful in the treatment of the asthma. So لما بنحكي على lipoxygenase inhibitors is more or less to do with the treatment of asthmatic patients. Now, corticosteroids or the steroids is a broad spectrum anti-inflammatory agents زي ما حكينا. It reduces the transcription of genes encoding COX-2, phospholipase A2, and pro-inflammatory cytokines including the interleukin-1 and tumor necrosis and INOS. The leukotriene receptor antagonist again block leukotriene receptors and prevent the actions of the leukotrienes, and therefore these drugs like the montelukast are useful again in the treatment of asthmatic patients. The other product or other metabolite which is generated from membrane phospholipids by the action of phospholipase A2 is platelet activating factor. This was discovered as a factor that caused platelet aggregation, but it is now known to have multiple inflammatory effects. It enhances, aggregates, and degranulates the platelets. It's a potent vasodilator and bronchoconstrictor. At low concentration, it induces vasodilatation and increased vascular permeability. Again, their effect on the leukocytes include increased adhesion to endothelial cells, as we have seen already, as well as in chemotaxis and degranulation, and also it enhances the oxygen burst to produce the oxygen species. Now, the next group of chemical mediators is what's so-called cytokines. Now, you need to know that cytokines are is a generic term which is called after the proteins secreted by many cell types, principally activated lymphocytes, macrophages, dendritic cells, also endothelial cells, epithelial cells, and even connective tissue cells, which mediate and regulate immune and inflammatory reactions. So any protein secreted by these cells and has a role in immune and inflammatory reactions is called cytokines. By convention, growth factors that act on the epithelial or mesenchymal cells are not grouped under cytokines. So we have a different group which we call growth factors, which are important in neoplasia, in cancer and neoplasia, as you will see probably in the next lectures. These cytokines have hormone-like, they are hormone-like polypeptides. They are produced by cells and involved in cell-to-cell communication, which means إنهم عبارة عن هم الميديا between cells to talk to each other. So cells, they use cytokines to talk to each other and to ask some cells to do some other actions, to potentiate their actions, to support them in the inflammatory process or in the immune response. We call these كلهم هذولا as cytokines. Now, these cytokines have diverse and pleiotropic effect, so including immunologic, hematopoietic, and pro-inflammatory activities. So they are also involved in the hematopoietic activity and the hematopoiesis and information of the bone marrow cells and bone marrow elements. Their secretion is transient, and they can exert their effect by either autocrine pathway, which means they are secreted from a cell to have their effect on the same cell, or to have their effect on an adjacent cell, nearby cell, which we call it paracrine, or even to secrete these cytokines in the circulation and have their effect at a remote or distant cells or tissue, which we call it the endocrine effect. The main classes of cytokines include regulators of lymphocyte function, which are the interleukin 2, which stimulates proliferation, or transforming growth factor beta, which inhibits lymphocyte growth. The other group are primary responders to injury, which we call it the innate immunity, including the interleukin 1 and tumor necrosis factor. Activators of cell-mediated immunity, including the interferon gamma and interleukin 12, chemotactics, which are the interleukin 8, and the hematopoietic growth factors, including interleukin 3 and GM-CSF. From this table, I need from you to know that the following cytokines are involved in acute inflammations, which include tumor necrosis factor, interleukin 1 and interleukin 6, as well as the chemokines. Interleukin 17 is also another cytokine which is involved in recruitment of neutrophils and monocytes, but it's not as important as the previous four ones. The cytokines which are involved in chronic inflammation include the interleukin 12, as well as the interferon gamma, and interleukin 17 also, which is involved here in acute and chronic inflammation. And you can see here the principal sources and the principal actions in inflammation. As I said, I need to know that these are the main mediators in acute inflammation, اللي هم tumor necrosis factor, interleukin 1, interleukin 6, and the chemokines. So we can see that there are different major rules of cytokines in acute inflammation. On the left side, you can see here they can induce local inflammatory process and augment the inflammation. The tumor necrosis factor and interleukin 1 are known to increase the vascular permeability and increase the expression of adhesion molecules, and also to enhance the chemokines. And this will potentiate the whole inflammatory process. In the middle here, you can see that the cytokines and, especially the tumor necrosis factor, interleukin 1 and interleukin 6, also can produce systemic protective effects. For example, they induce the brain, and this will lead to the, will lead to fever, which is one of the protective mechanisms against inflammation, which is induced by the brain and with the effect of the other prostaglandins. The interleukin 1 and interleukin 6 also will enhance and stimulate the liver to produce the acute phase proteins or acute phase reactants of inflammation, and also will stimulate the bone marrow to produce more leukocytes and more hematopoietic cells and hematopoiesis. They also can have systemic pathological effects on the heart. For example, tumor necrosis factor might lead to heart failure and low output. A tumor necrosis factor effect on the endothelial cells and blood vessels again can lead to increased vascular permeability, and also it's a thrombogenic, which means might lead to thrombosis, and also can lead to skeletal muscle wasting, because it enhances the catabolism of the body, and also the insulin lead to insulin resistance. So tumor necrosis factor and interleukin 1 are produced mainly by macrophages. Secretion stimulated by bacterial products or immune complexes or endotoxins or physical injuries or other cytokines. They exert their effect on endothelial cells, on leukocytes, fibroblasts, and acute phase reactions. Tumor necrosis factor antagonists have been remarkably effective in the treatment of a chronic inflammatory disease, particularly rheumatoid arthritis, psoriasis, and some types of inflammatory bowel disease. So these tumor necrosis factor antagonists, and there are a lot of these different types of medications which are based on antagonizing the effect of a tumor necrosis factor, and they are now widely and commonly used, especially in rheumatological disease in general, as well as in inflammatory bowel disease. Again, this diagram also summarizes the major effects of interleukin 1 and tumor necrosis factor. And as we see here, the secretion of these cytokines is induced by different things like bacterial products or immune complexes or physical injury. And this will activate the macrophages or other cells to produce them. They can have acute phase reactions, which include fever, increase in sleep, and decrease in appetite, and increase in acute phase proteins or reactants, and might lead to some hemodynamic effects like shock because of the vasodilatation and to neutrophilia. They can have endothelial effect where increase leukocyte adherence and increase the prostaglandin I synthesis and increase the procoagulant activity and decrease the anticoagulant activity, and that's why they might predispose to thrombosis. And also they have fibroblast effect, so they increase the proliferation and collagen synthesis and collagenase secretion, as well as proteases and prostaglandin E synthesis. Also, they can have leukocyte effect where they increase the cytokine secretion by other leukocytes. Chemokines, on the other hand, are a group of related chemotactic polypeptides, all of which have four cysteine residues. Chemokines are a family of small proteins, which are usually 8 to 10 kilodalton, that act primarily as chemoattractants for specific types of leukocytes. However, there are about 40 different chemokines and 20 different receptors for chemokines, which have been described and identified. In general, these chemokines regulate adhesion, chemotaxis, and activation of leukocytes. They are important for proper targeting of leukocyte to infection sites, and they mediate their activities by binding to the 7 transmembrane G proteins coupled receptors, if you can remember them, that we discussed probably in the first lectures. They have two main functions: an acute inflammation as inflammatory chemokines, and also they have another function, which is the maintenance of the tissue architecture, which we call it the homeostatic chemokines. And these are produced constitutively by stromal cells in tissue. There are different families and different types of chemokines. You are not required to, memorize any of these because these are so detailed and there are so many of these chemokines. So مش مطلوب منكم لا تحفظوا ولا شيء. بدي بس from this slide to know that it is difficult to develop chemokine antagonists that suppress inflammation because of the functional redundancy of these proteins. So it's very difficult so far to produce these antagonists for chemokines. The last chemical mediator to be discussed in this lecture is the nitric oxide that we have already discussed its action and functions on previous occasions. This nitric oxide is produced from the arginine by the effect of nitric oxide synthase اللي هو NOS. There are 3 isoforms زي ما حكينا سابقا اللي هو ال NOS وال INOS وال ENOS. Their role in inflammation include vasodilatation, so the smooth muscle relaxant, antagonist of platelet adhesion, aggregation, and stimulation, and it reduces the leukocyte adhesion and recruitment, and also it has a microbicidal effect in activated macrophages. So therefore, the outcome of the action of the nitric oxide is to decrease the inflammatory response. So again, nitric oxide is a soluble gas produced from arginine by the action of nitric oxide synthase. زي ما حكينا it participates in the microbial killing with different types الendothelial, neuronal, inducible. E والN الendothelial والneuronal are constitutively expressed at low levels, and the NO, the nitric oxide they generate, acts to maintain vascular tone and as a neurotransmitter respectively. The INO acyl inducible NOS is involved in microbial killing, is expressed when macrophages are activated by cytokines like the interferon gamma or microbial products and induces the production of nitric oxide. Again, this is the last slide of this lecture, and it again summarizes the actions of the nitric oxide. And as you see here, the nitric oxide, it stimulates the endothelial, so endothelial stimulation, and also leads to vascular smooth muscle relaxation and vasodilatation. The nitric oxide effect on the smooth muscle and into the endothelium also lead to reduced leukocyte adhesion, and their effect in the platelets on the platelets is to reduce again the adhesion and the platelet aggregation here. And in the, as you see here in the macrophages, it activates the microbial killing or the microbicidal effect of the macrophages to kill the microbes. So it has a cytotoxicity effect on these microbes. So by this slide, we conclude the third lecture, which is, I think, is a very important lecture, and it has very strong pharmaceutical and pharmacological links to what you really study. Probably you have studied or you will be studying in the future about the different aspects of these medications that counteract the action of these chemical mediators. Thank you, and I think we'll be meeting in the next lecture, which is the last lecture for me. Thank you. Assalamu alaikum.